Prabhakar Singh for this talk on newer diagnostics in microbial keratitis.
But the bugs. So what we exactly do when we see a case of microbial keratitis, we examine them on slit lamp, we have clinical clues, then we do corneal scraping, we subject it to microscopic examination, and we start the patient on treatment, and depending upon the final culture sensitivity report, we modify it subsequently, and this is considered to be the gold standard. However, there are certain challenges that are associated with the conventional techniques. There can be overlapping clinical features at times. There can be polymicrobial infection. We know that there is a wrong diagnostic turnaround time and there is low culture positivity rate. So, to overcome this clinical scenario, advance me. So to overcome all those challenges, we have newer diagnostic modalities that are there now, which I will be talking subsequently. So let's start with polymerase chain reaction. We all are aware of this technique called polymerase chain reaction. We amplify the DNA, targeted DNA fragments, and we know that even a small amount of material is sufficient here because that will yield a positive result. And we have an advantage that we will be having a rapid turnaround time. The susceptibility can be determined very rapidly. And for prokaryotic cells, we have 16S ribosomal DNA PCR. For eukaryotic cells like acanthamoeba and fungi, we have 18S ribosomal RNA PCR. And of course, to identify higher species, to have a higher species level resolution in fungi, we have the internal transcribed spacer areas or genes, and this is why it is known as primary fungal barcode marker. Apart from that, we can identify acanthamoeba, we can differentiate between herpes simplex keratitis and herpes zoster keratitis. However, there are certain disadvantages associated with it. That the targeted organism, there is only a targeted organism that can be analyzed, and it can even amplify the normal flora which is there, and therefore we will have a false positive report. And the microbial DNA that is detected even after the successful treatment. So even if your patient is responding to your treatment, the results will show that still the organism is surviving. And of course, there is very high cost associated with it, and there is a poor accessibility to it. Coming to the next the modality, that is a mass spectroscopy. So basically, I will call it as MALDI-TOF only. That is matrix-assisted laser desorption ionization with or without time of flight. So we do not worry with such a long name. Just remember that this helps you resolve pathogens to species and subspecies level. So how do we do this thing? So we just have a culture. We just have a culture here, and we just subject it to centrifugation, serial centrifugation with different materials, and then finally we plate it over a surface, over a matrix that is made up of 4-hydroxycinnamic acid. Now this is exposed to UV radiations, and this results in desorption, ionization, and subsequently, depending upon the mass to charge ratio, they will keep on moving towards the detector, and depending upon the mass to charge value along the x-axis and the intensity along the y-axis, you will have a spectra. And now you will compare the known spectra with the spectra that you have got, and you will have the organism in your hand. Apart from that, we have many other imaging modalities like anterior segment OCT. Dr. Kavya has talked about it, but I will talk little about it in microbial keratitis, though we will not get the organism per se directly, but yes, we will have certain clues which can be given by these modalities. So we can see that in early stages of acanthamoeba keratitis, we can see perineural infiltrates. Here you can see it can range in width from 20 to 200 microns in width, and somewhere from subepithelial to the mid-stromal level. Whereas if it is a case of HSV keratitis, early stage of HSV keratitis, like herpetic epithelial disease, depending upon the severity, the hyperreflectivity can start from the subepithelial level to mid-stromal, or at times can be from thickness also. As far as fungal keratitis is concerned, this has been said that you will be encountering cystic spaces in cases of fungal keratitis in AIOC, and this is how you make there is a clue that okay, this can be a fungal keratitis. Again, it's not a pointing to the organism per se, but this is what has been described so far. We are very much well aware about the in vivo confocal microscopy, which tells you and directly goes into the substance of the cornea and tells or gives you or shows you the hyper-reflective, high contrast linear structures, which are nothing but the fungi that is branching at almost 45 to 90 degrees. And you can also see the round hyper-reflective structures, which are nothing but acanthamoeba cysts and trophozoites. Coming to the next modality, so far we required, except for the AIOC2023, we required even for the conventional method and rest of the methods that I talked about, like PCR and Harditop, we require a lab, microbiology lab. But can we do without a microbiology lab? So this is something which will tell you as to we can actually manage even without having a good microbiology lab. So this has been described as there is a ligand. So what people have done, they have developed a hydrogel, and over which they have attached highly polymerized functionalized polymers, and these polymers have certain areas which are responsive to various microorganisms, gram-positive organism, gram-negative organism, and fungi. So you can see here that the red one are the polymyxin peptides, which will bind to only gram-negative organisms. That is the polymyxin peptide. The vancomycin, this one is the vancomycin peptide, which will bind specifically to the gram-positive organism. So whenever this is exposed to those organisms, it binds to it. Subsequently, there is dissolution of those polymers and branch polymers, and finally you can stain it with fluorescent dye and see it under fluorescent microscope, and you can have the organism. Quickly, I will tell you how we can translate it to our clinical practice. So this is the cornea which was infected. We placed these triple hydrogel onto the cornea for say 30 minutes, and subsequently we took it out and we stained this hydrogel with various stains, various fluorescent stains, and we have the organism. So even if we do not have a microbiologist center in the peripheral center, even a non-experienced person can just do this and tell you the exact diagnosis. Next generation sequencing again is based on your PCR, so I won't talk much about it, just a small thing that it is of two types. One is PCR targeted amplicon, which is very quick, and the second is shotgun metagenomic deep sequence sequencing, which takes into account all RNA and DNA, so it takes a little longer than that. And of course, artificial intelligence, even infectious keratitis, is not spared by this artificial intelligence. It is said that it can diagnose a corneal ulcer with an accuracy up to 70%, which was comparable to the ophthalmologists who were not a cornea specialists. So with this, I would like to conclude. Thank you.
Prabhakar for an interesting talk.